excited to spend an hour with you discussing the next stage of the RESECT study. I'm Kevin Gallagher, the RESECT study co-lead, a urology ST5 in the east of Scotland. Welcome to you and welcome to our panel and to the BURST team who are here working hard in the background to run this webinar smoothly for us. A special mention to Aqua, Arjun, Fortis, and Alex for their hard work in organizing the session. We'll start with some housekeeping for the meeting. So as you've probably just heard, the webinar is recorded for your knowledge. It will be posted publicly on YouTube afterwards. Due to the number of attendees currently have no video or audio. However, we want you to interact as much as possible by discussing and submitting your questions. You can submit formal questions that will only be seen by the panel in the Q&A box. Or for general discussion, we will also be monitoring the chat function. We have a team here to discuss with you and to bring any significant or interesting points out of the panel, out for the panel to discuss. We want the webinar to be discussive and as interactive as possible. We will have two short presentations, first from Nikita giving us an update on the study progress, and then I will talk about how and when to do the prospective phase of the study. Both of these talks will be followed by plenty of time for open discussion, and we're keen to answer as many of your questions as we can. At the very end, just like we did with our last webinar, we will stop the recording and invite any attendees who wish to stay for a more social discussion to just stay on the call, and we'll unmute you and give you video and bring you in, and it will be just like a normal Zoom meeting. And at that point, please use the hands up function when you want to speak. So at this point, I would like to introduce our panel tonight. Guys, if you could just introduce yourself with the role in the study, your location and your current job position, that would be great. So welcome to Nikita.
Hi, I'm Nikita Bhatt. I work in Norfolk and Norwich in England. I'm an ST5 trainee and co-lead for RESECT with Kevin. I'm also co-vice chair of BURST, and welcome everyone. Glad you all could make it this evening.
Thank you, Nikita. Welcome to Eleanor.
Hello everyone, I'm Eleanor Zimmerman. I'm a trainee just finishing off my ST4 in the Southwest. And I'm part of the steering committee for RESECT.
Welcome to Meg Hannah.
Hi everyone, I'm Meg. I'm a trainee down in London and also currently doing a PhD. So part of the steering committee and helping with the sites in Asia, and then just part of the communications team in BURST.
Okay, thank you very much, guys. So at this point, I would like to introduce Nikita Bhatt, who will give us an update on the study progress. Nikita, if you could share your screen now and give your talk.
Thanks, Kevin. Can you see my slides?
Yes.
Perfect. So hi everyone. As I've already introduced myself, I'm RESECT co-lead, and I'm just going to update you today on behalf of the RESECT study team and all of our global collaborators about the progress of the study. So first of all, I'd like to say a huge thank you to all of our funders and sponsors, without whom this important work would not be possible. So I'm sure you're aware of this, but the main objective of the RESECT study is to determine if audit and feedback can improve the quality of TURBT surgery and reduce early recurrence rates. We want to do that by launching audit and feedback into the digital age. We want to innovate a global way of recording and feeding back surgical performance in TURBT surgery in a way that is surgeon-driven. So, as you all know, that we have a massive team involved with BURST in any study, but this is the amount of people that have gone behind RESECT already. And I have to say a huge thank you to all these people. And this includes our core steering committee through the wider BURST team, our external reviewers, national leads, statisticians, methodologists, software developers, and data managers. So just a little bit about the study recruitment update. We're very thankful that we already have over 1,000 collaborators recruited from 335 hospitals spanning 49 countries. And as of today, we have 3,476 patient records entered into our system. If you would like to look at the live league table, it's available on our website on this address. Even at this early stage, RESECT has made some major achievements. The hospital and collaborator recruitment has exceeded our expectations. We're thrilled, as I said, to have already over 3,500 patient records. We also ran the first webinar for RESECT earlier this year in March, which was a huge success with over 150 attendees attending live and an active discussion, and then subsequently almost 200 views on YouTube. If you wish to look at this webinar, it's still available on YouTube for your reference. We've also built various software solutions to improve the utility and experience of the users engaging with the study platform. For example, the solution to the index operation CRF, this one, allows anonymous linking of surgeons registered at your sites to the operations they have done. This page also displays the site-specific information, such as the site recruitment summary and your date of site registration. We hope that this has resulted in fast and intuitive data entry experience, and feedback so far suggests the case. You can look at feedback from our collaborators on Twitter and understand how this works if you haven't started data collection already. So this is the leaderboard that is available live on our website, and it's updated every day. And we're really thrilled to see that so many hospitals have started their data collection already. And as you can see, the data collection is quite international, and currently Turkey is leading this. So I'd encourage you to start your data collection if you haven't done so already. So thank you, first of all, for all of you who have already registered. It is great to have all of you registered, but it's really important that you start the data collection as well. So this graph is just showing some selected countries where they have already started data collection. On the left are the centers that have started collecting data, and on the right are those that still haven't collected any patient data. So I'd encourage you, if you have registered, if you haven't started data collection, please start doing so soon. The other important point is about approvals. So remember that even if it is not required in your hospital, you still need to complete this approval form. The access form, if you haven't already done it, was sent to your lead collaborator at the time of registration. We're pleased to say that over 70% of you have already completed this form. If you have any issues and you can't find the link, etc., want us to send it back to you, please email us and we'll be able to send you this link again. So the next step here is all sites, all of you who have already registered and filled in patient data will be given access to a dynamic live performance feedback dashboard. As per the study protocol and the site agreement that you all signed, the timing of access to this will be varied so that we can determine what, if any, impact it is having on your practice. Sites can download their own data at any time they wish. You own your own data. We are also working really hard to build a dashboard that is of maximum use to you and the surgeons at your hospital. So it will be hospital and surgeon anonymous, so you can tell which data point is your hospital, but not any other hospital or surgeon. It will update in real time from data entered into the database. You'll be able to look at comparative performance between different hospitals and surgeons. It will also allow filtering of the data so that specific types of cases can be assessed so that you can better understand reasons for your performance and develop strategies to improve. It will include educational and practical resources like videos. So this is an early example of what it might look like. We're still developing this and refining this. The idea is that you can see where you sit and compare it to other hospitals, as you can see from the graph here. But of course, differences in achieving quality indicators may be due to a lot of factors. So our aim is not to name or shame anyone, but to investigate and understand your performance and compare it internationally. For instance, we will build an option for you to subset the data by types or size of tumors and to investigate individual surgeon performance within this. You can identify cases where the outcome was not achieved and look at why. Thus, you can develop strategies to improve, or perhaps you will determine that performance is appropriate for your own case mix. So we want you to have this, to be able to review your performance and compare it with hospitals around the world. And then finally, as a lot of hospitals have their changeover during July, August, or October, there are a few things that we need to keep in mind. So the lead collaborator is really responsible to ensure that the hospital meets requirements for all phases, ensure that all hospitals and their author and their collaborators are meeting the personal contribution requirements agreed by your team. If you want to look at the authorship criteria, it's available on our website. But broadly, it's 25 prospective and 25 retrospective cases, and then 10 for each new collaborator. And you add and edit existing collaborators on your site collab form. If you want to change the lead, if you're moving a hospital, you can contact us and we'll be happy to assist you. And it's at this point, you can also get new helpers to spread the data entry load, and you can add these at any time. If you're leaving hospital, then the lead must ensure that somebody is going to complete the prospective phase after you leave. And the lead must be happy that you've met the authorship requirements. So we're going to deal with this quite individually. So all sites have their own autonomy on how they want to do this, as long as they meet the broad authorship criteria, and we're happy to assist you with this individually. And you can also split your contribution with old and new hospitals. So you check if the new hospital you're going to is already registered, and you can also request a site switch if you wish by contacting us. Thank you.
Thank you very much, Nikita. Very useful, informative talk. Could I now ask Eleanor, I don't know, has any specific questions been asked in the chat or in the Q&A section that you would like to pose to Nikita or any of the panelists at this stage?
Thanks, Kevin. I think we're okay for the minute. There's no questions so far, but perhaps
okay.
After the next talk.
No problem. Everyone, I very much encourage you, if there's any burning questions, please do fire them into the chat or the Q&A box. It'll contribute to more lively discussion. But we did have some pre-submitted questions and things that we find asked commonly in the emails. Nikita, I'd like to ask you from one of the collaborators in the pre-submitted questions, and you covered it to some extent in your talk. I'm moving hospital. However, can I remain as a lead collaborator?
Yeah, so again, it's very site specific. If you're moving hospital and if you're going to a new site where RESECT is already registered and they have their own lead collaborator, you can try and switch if you wish. You can be co-lead on the original site that you were already collecting data for. It depends on how much work you've already put in. So if you've done a lot of work with regards to study admin, ethics approval, identifying patients, or in fact collecting retrospective data already, you can have a site agreement where you can remain lead for your old site. For example, if you live close by and can continue contributing in some way, you can still remain lead in your old hospital. However, if you are switching to a new hospital, you can speak to your old site to see if you can continue being co-lead in the old site whilst being in the new hospital. You can also decide to register RESECT in your new site if it's not already registered. The time limit for that is sort of quite tight now, but if you do email us and if you're keen, we'll find a way of working that through with you as well. But if you have any questions that are site specific, we are happy to help you in your individual situation.
Okay, thank you very much, Nikita. Eleanor, is there anything coming into the questions just now?
Yeah, we have a couple of questions. So the first one from Federico, he's just asked if we could just clarify when and where the collaborators will have access to the dashboard. So if you wouldn't mind just going over that again, please, Nikita, that would be great.
So we're still working on the dashboard, and once the retrospective phase is over and before we start the prospective phase, more or less most people will have access to the dashboard. But as I said in my presentation, the access to the dashboard and the educational resources will be varied. And that's something that we all signed in our in the approvals department before you registered for the study. So this sort of feedback will be varied. So you could be getting it at a different time than somebody else who's registered, and that's the whole aim of the study. But it will be before you start the prospective phase.
So I just to clarify, sorry, you're right, Nikita, that the timing of it will be varied. We want to be clear, everybody will get access to exactly the same feedback by the end of the study. The two main points where it will be provided are for half of the sites, you will get it at the end of the retrospective phase before you begin the prospective phase. For the rest of the sites, you will complete your minimum prospective requirement before you're giving to the access to the feedback dashboard.
Right, I think that's very clear. Thank you both. Another question that has come in from Ima Ibiok is a tricky one. I'd like to direct that to you, Kevin, if possible. We've got the question of how do we, as lead collaborators, deal with a collaborator who has not contributed anything or shown a particular interest in data collection, and how and can we go about replacing them with other interested parties?
That's a good question, and it covers sort of many points that I guess we get asked through the emails. Firstly, if you feel as the lead collaborator that somebody's not pulling their weight, it's certainly you're right as the lead to make that assessment. If you are not the supervising consultant, I'd highly recommend that you discuss the issue with the consultant in charge so that you can both agree on the best way to approach it. Obviously discussing it with the person involved and asking if they're willing to meet the requirements that are set out in the study documentation. So that's there for you as your backup to be able to tell the person, look, the authorship requirement as stated by the study is this. Do you think that you're going to be able to do that? And if they're not, then practically, how do you go about removing them? So as in agreement with your supervising consultant that is required, then the lead collaborator will have the ability to go back to their collaborator form. So when you registered, you were sent a link to your collaborator record, which can be edited at any time. So if you need to remove somebody, you can just go back there, remove them yourself. And if you want to add somebody new, you can do it exactly the same way on that form. So just to repeat, that link was sent to you at the point you registered for the study. So you can search back in your emails and find, and if you still struggling to find the link to your collaborators form, then please do email and we can get it sent back to you.
I think there's one more question, sorry. It says, how long is the retrospective phase open for data entry?
That to put simply, I'll make this point again in my presentation, the retrospective phase will never close. It's open for the entire study, and data entry currently looks like it's going to be open until October 2022. The reason for that is although we require a minimum of 25 cases in the retrospective phase, again, I'll cover it in my presentation, for you to progress to the prospective phase. To complete the study, some sites will need more than 25 based on the number of authors they have. But you can finish the cases beyond 25 even after you've begun the prospective phase. And that's because the prospective phase is only going to give you, dependent on what sort of volume your site is, 4, 5, 6 cases a month. So you'll have time waiting for the prospective cases to occur to continue working on your retrospective data, but you must have done 25 retrospective before you can begin the prospective. If we'll maybe try at this stage, if there are questions that I'm going to cover, we'll defer them until I give my presentation, just from a time point of view, but that is a good one I'm happy to repeat.
I don't know, should we address the Q&A questions now, or Kevin, do you want to start presenting and then we can answer them at the end?
Yeah, we're good for time, but I think it's probably a nice point to just move on, and I can cover some more information about the prospective phase, because it's clear that that's where the burning questions lie. And then at the end of my talk, Eleanor, again, then maybe you'll get a feel for which questions are answered and which questions we should come back to and give a bit more attention to. Okay, so I'm just going to share my screen now. So good evening, everyone. Thank you for joining. I'm going to cover the principles of how and when the prospective phase will start, and how you should do it, and keep it very short, really, because all of the very detailed information that you're going to need is going to be sent to you individually, related to your own site, in emails, and also then available in the study manuals that you can find on the website. I would like to thank again the sponsors and research grant providers for the study, because they're the ones who really have made this possible. So to just answer the question very simply, when will the prospective phase begin? The first sites will begin it, we're hoping, at the start of October 2021. It's slightly dependent on a few things, but that is the current aim. What that means is, from our point of view, the prospective phase is open, but not all sites will begin at that stage, because not all sites will have completed the retrospective phase. And the study has been designed in that way so that sites can progress through the study as they as fits them, with certain deadlines, but not everybody will start then, but that is when it will be open from the study management point of view. So if the prospective phase has started, are you too late? And I just want to re-emphasize that point, because I don't want people to think that prospective phase started, I've missed the boat, we're too late. That is not the case. There are lots of boats. Once we've opened the prospective phase of the study, sites will be invited to begin as they finish the minimum requirement of the retrospective phase. And as I said, you can progress to the prospective phase when you've done 25 retrospective, regardless of what you actually need to do for your total author requirement. And that is so that you can get on to counting prospective phases as quickly as possible. And say you've got, you have many authors and you need to do 100 retrospective cases. That may cut into your prospective time if we were to wait for all 100. But as I said, during the prospective phase, you'll have time to go and complete your retrospective cases. The data entry for the retrospective phase will not close throughout the whole study. But we will at some point prevent new sites from beginning the retrospective phase. That sort of officially has ended, but if a site can email us and tell us that they are able to do the retrospective phase very, very quickly, and they have a good case volume that they think they can complete the prospective phase in the time period, we may individually give access to new site registrants at this stage. So although the prospective phase will open, from our point of view at the beginning of October, there are steps that need to be ascended in order to progress from the point of view of a site. And the basic requirements that need to be completed before you get the final invitation to begin prospective case counting are: you must have completed your approvals form, and the study agreement must have been signed. The study agreement is in the site registration form that you complete and sign. You must have done a minimum of 25 retrospective cases, and 20 of these must have been first tumors, and we'll check this before we progress you through the study. At the point of completing the 25 retrospective cases, you will receive specific instructions from the RESECT team. And as per the study protocol, half of you will be given feedback at this stage, and the other half will be given their feedback at the end of the prospective phase. So once this communication with you is completed, you will be sent a link to what we call the midpoint survey. And this is a very, very short survey, which just asks you a few simple questions. You hit submit, and once you've hit submit, you'll get an email saying you can now start the prospective phase. So the bottom line is you'll be guided through the process via emails from the study team. So it's absolutely crucial that you are getting the emails and that you're reading them, particularly the lead collaborator. But as a backup, we're currently sending the emails to everybody just in case the lead collaborator is missing them or has moved on and hasn't told us. And that you read them and take action so as not to delay your progression to the prospective phase, because the sooner you get to the prospective phase, the more cases you're going to be able to recruit. And obviously it's more difficult to recruit cases to the prospective phase because they haven't already been done. If you think you're not getting the emails, please contact the team as soon as possible, and we'll make sure, we'll tell you what emails have been sent and we can check whether you've been getting them or not. All emails for the study come from resect@bursturology.com. Put it in your safe senders list and you'll be sure to get the emails. So to be clear, you're going to need to designate a date from which the cases count as contributing to your prospective phase. And don't worry, actually, the database is going to do that automatically, but you want to know so that you can begin your case screening. And it's after the date you receive the confirmation email when you complete the midpoint survey. And it'll all be very clear to you once it opens, because you'll be taken through step by step. You'll get the midpoint survey, you'll complete the midpoint survey, you'll get an email saying start prospective phase. And as I said before, why have you not received your survey? So that either you're not getting the email for some reason, or one of those steps that I just mentioned have not been completed. You've not done your approvals, you've not signed the study agreement, you've not done 25 cases, or you've not got the 20/5 cases split correct. And we will be sending sort of reminders and status alerts to the sites to let them know how they're getting on with those steps. So practically, how do you do the prospective phase? And the simple answer to that is that it is exactly the same as the retrospective phase. You after the date you complete your midpoint survey, you can start screening cases. Use the same case screening log, the same eligibility, inclusion and exclusion criteria for the study. You log into REDCap in exactly the same way, and you just make a new case like you did for the retrospective case, and the database will figure out whether it's retrospective or prospective. An important thing to remember, though, is that one of the eligibility criteria for the study is that the case must be confirmed transitional cell carcinoma, and therefore you must know the pathology before you can include the patient. Therefore, although it's called the prospective phase in that you know it's happening going forward, you will screen the cases and collect your data retrospectively once you know the pathology from the TURBT. And I recommend that you do that probably roughly a month in lag. That's what I would do. I would sit at the end of October and go through all the cases in September. At the end of November, go through all the cases in October, and screen them and start entering the data for the ones that are eligible, and then enter the follow-up data as I go forward. The reason that this will be helpful is that it's better for you to not have a huge amount of data to collect later on, but as well as that, it's helpful for you to have, for your own audit purposes, to have the data coming through in real time. So we've had this question asked a couple of times, and I just thought last minute that I would add this slide in, hence it's black and white and not all designed like the other ones. But I want to say you must assess the consecutive series of first and recurrent tumors separately. So people have asked, if I just screen consecutive TURBTs at my hospital, there's no way that I'll get 80% new and 20% recurrent, because we do far more recurrent than we do new, and that has to be a fact. But you should treat the series separately. You should count 20 first cases consecutively in the first case series, and the rest consecutively in the recurrent case series. I hope that makes sense. So finally, to timelines. So although we say that we the studies progress, sites progress through the study at their own pace, and the study is dynamic in that sense, and it really helps sites to come on board at different times, and we did that on purpose. There are going to be deadlines, and the sooner you get started, the longer you will have to collect data, and that is the most important point. From the point the prospective phase opens, data entry will remain open for a year. So at the minute, we hope that the prospective phase will open at the beginning of October, and data entry will remain open until October 2022. So if a site was ready to go in October 2021, so there are already, I think at last count, something like 60 sites that have already completed all of the requirements for the retrospective phase and are sitting chomping at the bit to get on to the prospective phase. And all of those sites will be invited as soon as we are ready for the prospective phase to begin. If they start in October 2021, they can collect their prospective cases every month. They'll start entering data maybe a month later, once they've followed our completed the survey and followed our instructions in the emails and have the pathology from their first cases back. They'll enter data at the end of every month going forward. But remembering that they're going to need to collect 3 months or first follow-up check cystoscopy data about all of the cases in the prospective phase. So we're talking about completing case recruitment, so new cases done by the end of June 2022, with the last follow-ups by October. Although accepting follow-ups can take a little longer than 3 months on some occasions, we allow up to 6 months to be counted as an early recurrence, and so we're looking for final database lock potentially by December 2022 or January 2023. That is the timeline as we're looking at it. It fits very nicely with the start of new registrar rotations in the UK, and I hope that that looks like a good year hitting the study at full speed, and with a nice endpoint in sight where we'll all have our data, we'll all have our feedback, and we'll start seeing some nice outputs from the study. So back to our saying that we're trying to launch audit feedback into the digital age, and I hope that we are proving that so far. I look forward to taking your questions.
Thank you, Kevin. I think that was very clear and has certainly answered a lot of the questions that were popping up in the discussion. And thank you also to the audience that have continued to ask questions as we go. If you feel that you would like more clarification above what we have written in some of the answers, do please say so, and we can rediscuss them. Excuse the toddler in the background. I was wondering, Kevin, if you could answer one of the questions that I think will be quite important to address today, actually. Someone has asked if they can present their local results, whether they could present them locally or at national conference.
Yeah, so there is we have a policy on the website about publication of data, but absolutely, your as we said, as Nikita said, your data is your own. So for your actual case series, you can access the raw data from the REDCap database anytime you want. And that's the same no matter what group you're in the study, either the early or standard feedback group. You can download your own data, present it locally, and please acknowledge the burst urology group as per the guidance in a document on, I think it's in the resources page of the burst website, but yes, you can, put simply. Anything above local, so if you're submitting to a regional or national conference, we the policy says that we need to see the submission before you do, but locally you can do what you want with it, as in at your own hospital.
Thank you, Kevin. Another quick question that has just come in on the inclusion criteria, and just clarification as to whether a cystoscopy and biopsy, provided it obtains histology of TCC, would be allowed in the study. Yeah.
Yes. That's in that should be relatively clear in the inclusion exclusion criteria. The stipulation is that biopsy procedure was intended to be the curative procedure for presumed non-muscle invasive bladder cancer. So this is for a small papillary tumor, like a 5 millimeter papillary tumor, where you decided that you were going to remove the whole thing with a biopsy forceps, and that was the definitive treatment. You cannot include a biopsy diathermy procedure of a diffuse lesion, so that is clearly not cured by you sampling it. That's not a curative procedure, that's a diagnostic procedure, like sampling of diffuse CIS. If you took a biopsy of a diffuse carpet-like lesion that you cleared and remove all of it, no, that's not curative intent procedure. So I hope the distinction there is clear.
I'd just like to add that remains the same for the retrospective phase. So the prospective phase inclusion criteria is exactly the same as the retrospective phase. So that should just fit in.
Okay. Anything else in the chat or questions at the minute, Eleanor?
I think that's it actually from the chat for now. So perhaps we can move on to the next session.
Yeah. I was going to ask Megs. There were quite a few submitted, pre-submitted questions. Was there anything there that you think we haven't covered that we should have a quick discussion about at this stage?
Perfect. Thanks, Kevin. So some of this I think you've covered, but I'll just go over it again because quite a few people have asked us, so probably just worth clarifying. So one of our questions is from Dr. Abdul Rauf, who's from Egypt, and this may be the case for lots of centres due to COVID. So he says that their department has far more retrospective cases than prospective cases at the moment, as they're performing less TURBT. So is it all right if they do input more retrospective cases?
The simple answer is yes. You can submit as many retrospective cases as you wish. Please submit thousands if you want to. You're never going to have thousands of prospective cases to match them to. So if you read the case requirement guidelines in the study documentation, The minimum requirement is 25 retrospective, 25 prospective. If you do your 25 prospective, you could do 100 retrospective if you wish. The benefit of that is twofold. Firstly, you're going to have more of your own local data that you can assess and get more meaningful outputs from in terms of individual surgical performance and use to your own avail. The second benefit is that for the league table at the minute, we aren't planning to make a distinction between prospective and retrospective cases. So you'll be further up the league table if you submit lots and lots of retrospective cases. But I'd highly recommend that for the prospective phase, you include every TURBT that is done in the time period, because it's unlikely that that is going to be a huge burden. Very few places are going to have more than 4 new tumors a week would probably be a high volume center, 4 to 6 new tumors a week. So it's completely doable to submit every prospective case.
Perfect. And then just another point, which again you did mention, but a common question that's come up. So if the centre is enrolling all of their TURBTs in a consecutive fashion, they may not be able to have the 80-20 split, as we've mentioned, so new cases to relapses or recurrence. So, and this could be to anyone on the panel, are there any sort of tips for them to overcome this, or anything that we just need to stress about that data collection?
Yeah, Eleanor, I wonder, am I struggling to explain that, because it has been asked a few times. How would you explain doing consecutive series, but still having an 80-20 split of first and recurrent cases?
Yeah, so you're quite right. It is a bit of a head scratching moment. My tip would be to focus on the new cases. So you have your consecutive list of cases, and as you go through, you keep a tally of how many you have that are new and how many you have that are recurrent, and you keep going until you reach the minimum number of new cases, and then you can decide whether you want to keep going or not. And in parallel, you observe how many recurrent are being entered at the same time.
Yeah, various approaches, I suppose. You could, elect to just do new cases initially. So you only go through the new cases, because that's the main bulk of the work, right? And when you've hit 20 new cases, you could add 5 retrospective, but it's got to be new, one after the other, to make them consecutive new cases or consecutive recurrent cases. Or completely separate the lists might be the easiest way to do it.
Thank you. So I'll sort of ask 2 questions in one go, if that's all right. The first question is it too late to register for the study, and when will the prospective phase begin? So again, I think you have mentioned this, but just to clarify for everyone.
Yeah, so to be clear, we have sort of said on the website that formal site registrations are now closed, and the reason for that was that we didn't want sites anymore to be able to just automatically register without us having a bit more discussion with them. And the discussion that needs to be had is basically, can you complete the study requirement? Can you give us confidence that you can complete the study requirement by the end of the study, which is currently looking like October 2022 formally. And that's completely achievable if you say, well, all our retrospective cases are already done, and the prospective phase is only opening, so we're going to bash out 25 retrospective cases in a matter of weeks, and we'll be ready to go with the prospective phase. Then great, of course you can start, but we'd like to have that discussion with you.
Perfect, thank you. So just another sort of practical question, which again we've touched on a bit, but obviously some centres might want to change their collaborators. So what's the sort of easiest way for them to do that, and let us know?
So for simple collaborator changes, we're keen that you take control of this yourself, and you can manage the study at your own site. And to do that, you can re-access your collaborator form at any time via the link that was sent to the lead collaborator at the time of registration. And if you can't find that link, please email us and we will resend it to you. With regards to changing the lead collaborator, is a little bit more complicated. And if you want to change the lead collaborator at your site, please just email us directly and we'll work through that with you. Because some of you guys been monitoring the email account and replying to emails, seen some of these issues coming through, Megs?
Yeah, we have seen this because I know for lots of places, particularly the UK, this is a sort of change over time for trainees.
To me, that's really encouraging that sites are managing the changeover, and that now that the new cohort are in, this is the great opportunity, just as the prospective phase opens, to get a new cohort of doctors on board, just as the exciting part of the study is ramping up. And there's lots of ways that you can balance the contribution of any of old team versus a new team or a continuing team. And if you're struggling to do that yourself, please do just get in touch and we can have a chat.
Perfect. And then just one final question. So this is about sort of supply of intravesical chemotherapy, and some centres have had an issue with this, and so therefore are not able to administer it after their procedures. So the question about this is, can they still enter their data, and does this affect what they're entering? Can they do the prospective phase, etc.?
So this is a point that illustrates an important principle about the study. No, it makes no impact on your ability to do the study. And the reason is that the study is an observational study of usual practice that mandates no, it doesn't mandate any change to your practice. And that's why it's an audit, an observational study. So even if we have hospitals in the study, from middle income, low income countries who have never been able to give intravesical chemotherapy. And that doesn't matter. That's what we're studying, the differences in practice and the impact that this has on patient outcomes. So please, all kinds of practice, we want it included. We want to observe what this does for TURBT surgery and patient outcomes. We're really interested to know about all these different ways and things that have been happening, particularly with the pandemic.
Perfect, great. That's everything from the pre-submitted questions. I don't know if anything else has come up. There's just one question that's come up. It's quite interesting. So the question is, do we need any education or any reflections for the surgeons before they start the prospective phase?
So I feel like I'm taking all these questions, but a lot of things that I feel strongly about, want to get the point across quite clearly. So before starting the prospective phase, as we said, half are going to get access to the feedback dashboard, and we maybe recommend some things that you might want to do with that. For the rest, we're not mandating anything. We're just observing your practice and seeing what happens. So what you do is up to you. And that's why this is an audit. We're not administering any forced intervention. So what you do with regards to quality improvement at your hospital is up to you. For half of you, you're going to get upfront access to some feedback that you might want to use. The rest of you will get access to this in a little later, and you can use it at that stage. But no, we don't mandate that you do anything.
Great, I think that was the last question that popped up.
Great, nothing else in the Q&A or the chat, Eleanor? Oh, time. Time flies, and that's us almost up to the hour, and I think that covered everything that we needed to cover. Had some very interesting questions. Thank you all for your participation. Really delighted that we had so many of you here tonight. As I said, the session's recorded. You can watch it back on YouTube, and we will. And anybody who didn't attend can catch up with this advice. At this stage, if you would like to stay, most of our panel is going to stay around for a chat. I'd be really interested to hear how you've all been getting on with the study, and not only that, how the pandemic is affecting you and the TURBT surgery at your hospital. So if you want to stay around, we'll stay online for another 20 or 30 minutes so that we can have a bit of discussion. And at this point, we'll stop recording so that we can speak freely.